afternoon, students. I'm Dr. Khushbu Mahajan, your dermatology educator, and today we are discussing the dermatology recall questions. First of all, I'm really sure that your exam went well and you would have done wonders there. So this session is not to scare you or not to tell you to mark yourself. This is more like a recall session where you are helping me out by giving me the questions which were asked in the exams. I have some questions with me, but I would love to get more and more input from you so that we have final questions which can later be uploaded on the PrepLadder app. Please don't mark yourself on the basis of what answers I give you today, because I'm sure questions may not be exactly same or the options may not be same. So we are just here to discuss the questions. So as I said, please give me more and more inputs so that we can discuss more. So one of the questions which I have is, annular lesions are seen in dermatology in all of the following except. So in a lot of our texts that we studied, we talked about annular lesions. Derma is more of a descriptive branch, and we all know that we see annular lesions in tinea corporis for sure. We see it with pityriasis rosea, where we know there are annular lesions with colorate of scales. Porokeratosis is another condition where you see annular lesions and there is scale crust which is there at the periphery. Urticaria pigmentosa is not something where I see annular lesions. Urticaria pigmentosa, as I have already told you, is a form of cutaneous mastocytosis, which you see in children around 2 years of age. And they present with more of urticarial lesions, which are edematous, erythematous, and itchy. They're usually not annular lesions. So this is one of the questions. If you have something else on this question, some other options, you're free to write it in the chat box and we can discuss it further. So here the answer, if it was the exact question, the answer should be urticaria pigmentosa. Thank you, Dr. Barrett. You also say that option B. And if there are any other options which I'm missing out, please write it here. The next question which I have is, which type of vitiligo doesn't usually progress in long term? So we have again discussed that there are various forms of vitiligo. There is focal vitiligo, there is generalized vitiligo, and there is segmental broadly and a non-segmental vitiligo. Segmental vitiligo is one which is usually present since birth. It is present along a dermatome and is usually constant at that dermatome. It does not progress in long term. Whereas focal, acrofacial, and mucosal vitiligos are all forms of non-segmental vitiligo, which are acquired, which are autoimmune, and so they have a tendency to progress in long term, right? So here, if these were the options and this was the question, the answer would be segmental, because segmental vitiligo usually does not progress. It is limited to that dermatome, and that is why it is also not very responsive to medical treatment or phototherapy. There is a speculation that here probably a neurogenic hypothesis is involved. So there is a neurotransmitter which is being released in that particular nerve area, and that is why you get that vitiligo. Yes, absolutely right. Not C, Dr. Barrett. Focal vitiligo can progress, and in fact, focal vitiligo can turn into vitiligo vulgaris, can increase in size or increase in number of lesions can be there. Right? So I hope these were the options and this was the question. Right. So next question which I have is, you had to match the following. On one side, you were given the relevant test, and on the other side, you were given the conditions in which you use the test. Again, I think a very, very simple question. So first test that I have is patch test, which we repeatedly have done, that it is done for contact allergic dermatitis. So patch test is done to diagnose the allergen in the contact allergic dermatitis. KOH mount, again, very, very simple, is used for fungal infections. So is used for tinea. biopsy can be used for both leprosy and lupus vulgaris. But look at the other option that I have, that is slit skin smear. Slit skin smear is used only in cases of leprosy and leishmaniasis, because here I need a tissue in which am I trying to identify the bacilli. So biopsy is for lupus vulgaris. So again, very, very simple here. So patch test, tinea. So one is patch test, one is C, two is D, three is B, and four is A. So out of this, option one would be the correct answer. Yes, absolutely right. I think all of you have marked it correct. So I have these three dermatology questions, and I would want your inputs into what other questions did you get, or what other topics were asked in the exam, so we can discuss that further. So I'll wait for your responses now. And these were the three questions which I had. I would want you to tell me more questions if there were. If these were the questions, I think it was very simple. Dermatology must have been a cakewalk for you. So I think there is no confusion with this question. Most of you are telling me the answers as option A, which is very clear cut. I request you to tell me what other questions were asked in dermatology. You can even write, if you do not remember, maybe you can tell me that there were no more questions. Even that would help me out. Okay, so Dr. Suman is telling a question. Genital region, vesicles in pregnant mother, upper chest and arm involvement in baby. HPE shows MNG cell. Is it HSV2 or varicella zoster virus? So, okay. So probably it is a question on congenital herpes, where, probably it was herpes genitalis, which was there in the pregnant mother, and she delivered a child who had upper chest and arm involvement, and histopath was suggestive of multinucleate giant cell. So if this was the clinical picture, thank you so much, Dr. Suman. It is very clear cut, a case of congenital herpes, which is caused by HSV, not varicella zoster virus. So varicella zoster virus, we know, causes chicken pox and herpes zoster. A mother with genital herpes would pass HSV to the baby, and the baby can get congenital herpes, which can present with vesicles which are there on the trunk, on the face, or on the body. So if this was the question, the answer would be HSV2, not varicella zoster virus. So thank you so much. So there was a case of leprosy drug, and it was showing hyperpigmentation. So probably there was a case of leprosy who was treated with multibacillary drug therapy, and the patient had presented with hyperpigmentation, and you were asked which drug is responsible for it. Yeah, what is responsible for this hyperpigmentation? So you all know that clofazimine can cause orangish red discoloration and even pigmentation in patients with leprosy. It can even cause ichthyosis. So probably it was something related to that. Please help me out whether this was the question, anti-leprosy drug causing hyperpigmentation. So we know there are three main anti-leprosy drugs, rifampicin, dapsone, and clofazimine, out of which clofazimine is responsible for pigmentation, ichthyosis, and dry skin. So if this was the question, the answer here would be clofazimine. Thank you so much. Any other question from dermatology? So again, these two questions I assume were quite easy for you. Clofazimine basically gets deposited in the lipofuscin granules, and it deposit itself in the skin, giving rise to an orangish red pigmentation and also ichthyosis. So I'll wait for another minute. Please tell me if there are any more questions which were asked or any other topics that you remember. There was nothing from pemphigus or hair loss. Usually these are the common things which are asked. So was there something from pemphigus group of disorders or from hair loss? No. Okay, great. So they asked you STD, they asked you leprosy and some basics. So I guess that's it. These were the 5, 6 questions which were asked in dermatology. And I can happily say that I think the dermatology part was really easy for you and you would have cracked it well. So all the best for your results and hope not to see you in these sessions and in fact see you in person sometime. Okay. So all the best. And I think, okay, so Dr. Parth is telling me there was something on Kawasaki disease. So can you elaborate what was asked about Kawasaki disease? And I think Kawasaki, if they asked you, it would have been something related to what not seen. So was it related to dermatology, what not seen in Kawasaki disease? Dr. Parth, do you have any options? What was not seen in Kawasaki disease? Purulent conjunctivitis. Okay, so I think this may not be related to dermatology per se. Right. Okay. So I think there was some question which was related to Kawasaki disease. However, I'm not able to get the options here and whether it was related to dermatology anywhere. So, okay. Yeah, urticaria can be a adenopathy, polymorphous rash, purulent conjunctivitis, what not seen in Kawasaki disease. So we know that Kawasaki disease can present with a rash. So that can happen. Adenopathy can happen. Yes, purulent conjunctivitis is something which is usually not seen in Kawasaki disease. Right? So I think that's it for dermatology. Thank you so much for giving me more questions. And I'll close the session here. All the best to all of you. Thank you.